picking up where we left off for part 2 of the hypertension pharmacotherapy lecture. Now we're going to talk about when to initiate treatment. So if patients have normal blood pressures, as in their blood pressure is below 120/80, we don't need to start any non-pharmacologic or pharmacotherapeutic options. We just want to tell the patient to continue what they're doing. We want to encourage a healthy lifestyle, and then just continue to reassess their blood pressure annually and make sure that it's still within this normal range. If a patient has an elevated blood pressure, as in 120 to 129, less than 180, then we want to start them on non-pharmacologic therapy. And we can reassess their blood pressure in 3 to 6 months. If it's still within this range, it's not great, right? It's not normal, but we would still just continue to promote a healthy lifestyle, continue doing those non-pharmacologic changes that they made. Hopefully over time, we'll see them go into a normal range. But at this point, we still don't consider these patients to have hypertension. So we're just going to recommend lifestyle modifications and keep reassessing their blood pressure. Now, when we get into stage 1 and stage 2 hypertension, this is when we're definitely going to make solid interventions. If they have stage 1 hypertension, we want to look at their ASCVD risk. So remember that calculator that we looked at in part 1. So if a patient has an ASCVD 10-year risk that is equal to or greater than 10%, and they have stage 1 hypertension, we start them on non-pharmacologic and pharmacologic therapy, and we reassess their blood pressure in 1 month. If they're at goal with those changes, we reassess them every 3 to 6 months. And if they continue to be at goal, we make those follow-ups less frequent and more spaced out. But if they're not at goal, then we want to assess for adherence, right? Like I said earlier, medication adherence is a big deal with hypertension medications, especially because patients aren't symptomatic, right? Why are you going to feel compelled to take a medication when you feel perfectly fine? So we want to address adherence. And then we also want to consider if they are perfectly adherent and they've made, lifestyle modifications and they're still not at goal, then at that point we want to consider stepping them up in therapy. So whether that's increasing the dose of the current medication they're on or adding on an additional medication. Hypertension is one of these disease states where, we're kind of throwing different mechanism drugs at a condition and mixing and matching to try to find the right fit for a patient. Now, on the other hand, if they have stage 1 hypertension and they do not have ASCVD history and their 10-year CVD risk is less than 10%, we can start with non-pharmacologic therapy alone. Then we can reassess blood pressure in 3 to 6 months. And if they're at goal, that's great. Continue to monitor, keep up those lifestyle modifications that they made that worked. If they're not at goal, then we want to consider initiation of pharmacotherapy. So it's an interesting difference here comparing, patients that are all stage 1 hypertension, but comparing the two groups between they do have ASCVD history or they do have a risk higher than 10%, and the patients that don't have ASCVD or have a risk less than 10%. These patients are kind of in that window where counseling them on lifestyle modifications is going to make the biggest difference, especially for patients that are like, look, I don't want to take any medications, is there something I can do with my diet or exercise or lifestyle that could prevent me from having to take medications? The patients in this category here are the ones that have kind of the most room to make those changes and see an actual decrease in their blood pressure that can hold off having to be on medications for a while. It might not be forever, but you would be surprised how long a ways lifestyle modifications can go. Then we have stage 2 hypertension. So on these patients, we are going to have to start pharmacotherapy right away. But one thing that I do want to note, you'll notice between all these groups, it's always non-pharmacologic therapy at the baseline. So all these patients, we have non-pharmacologic therapy for. So again, even if they're stage 2, we still recommend non-pharmacologic therapy, but at this point we're definitely going to add pharmacologic therapy right up front to begin with too. For these patients, we reassess blood pressure in 1 month, and if they're at goal, we reassess every 3 to 6 months and continue that therapy. If they're not at goal, again, we look at adherence issues and we consider stepping them up in dose of their current therapy or adding on another agent. Okay, so this slide basically says the same thing, that the threshold for starting drug therapy is a blood pressure above or equal to 130/80, and if it's stage 1 hypertension, if they have a 10-year ASCVD risk 10 or above 10, as in primary prevention, they haven't had ASCVD yet, that would be a reason to start therapy. If they have diabetes and or CKD and have a blood pressure above that level, that would be an indication. If they have ASCVD, this is considered secondary prevention because they've already had an event, but this would still be an indication to start therapy, with the accompanying high blood pressure level. And then if they had stage 1 hypertension, but they didn't have any of those 3 things, so we started with lifestyle modifications because that was appropriate for that patient at that time, but then after 6 months, they're still not at goal, then that would be an indication to start therapy. And then for stage 2, doesn't really matter, if their blood pressure is at that stage 2 elevation, we're starting pharmacotherapy and non-pharmacologic therapy. Alright, so this slide also, again, the same information, just presented a different ways. So whichever makes the most sense to you, either looking at the table or looking at this flow chart. But again, if a patient has normal blood pressure, we just continue to promote lifestyle habits. We'll check them out again in a year, as part of their annual checkup. If they've got elevated blood pressure, we start them with non-pharm therapy, reassess in 3 to 6 months, see if it's, kind of still here, which is okay, not ideal, but we would just continue doing this. If it's gone down here, that's great. Then we'll check them out yearly. If it's progressed to stage 1 at next follow-up, then, we follow this route. But again, for stage 1, the most important thing is looking at that 10-year ASCVD risk and determining whether non-pharmacologic therapy is appropriate alone for them or if they need non-pharm and pharmacotherapy. And then for stage 2, when we have that elevation above or equal to 140/90, then we want non-pharmacologic therapy and blood pressure lowering medication regardless of ASCVD or other comorbidities. So again, in the past, the cutoff was actually higher. It was 140/90 before we started therapy, but the guidelines have kind of tightened up a little bit because it really shows that patients can benefit a lot from starting antihypertensive medications earlier to prevent cardiovascular disease, morbidity, mortality. So I said this earlier, non-pharmacologic interventions come into play no matter what stage they're in of therapy. Non-pharmacologic therapy alone is especially useful for prevention or the patients with normal blood pressure or slightly elevated blood pressures, but we still want to encourage it in patients that have stage 1 or stage 2 hypertension. Even if they're under control, we still want to always encourage all of these approaches no matter where they are in therapy. So we have dietary modifications, weight loss, reducing sodium intake, increasing physical activity, and tobacco cessation. So we'll talk in detail about all these in the coming slides. Weight loss is one of the most effective ways to decrease blood pressure. Weight loss is recommended to reduce blood pressure specifically in adults who are overweight or obese. If a patient is already at a healthy weight or a healthy BMI, which is 18.5 to 24.9, then we don't need to recommend weight loss for them. But patients that are overweight or obese and not at their targeted healthy BMI, we can definitely recommend weight loss. And it's so effective that there's a pretty accurate ratio to describe and share with patients that for every 10 kilograms they lose, they can experience about a 10-point reduction in their blood pressure. You might want to convert that to pounds so that it makes more sense to them, but it's 10 to 10 is just an easier way to remember it. So very strong correlation between weight loss and blood pressure reduction. And how do we want to recommend patients lose weight? Through a combination of reducing caloric intake and increasing physical activity. So we want to make sure we're encouraging healthy ways to lose weight so that they can sustain that weight loss. The DASH diet is another way that we can decrease blood pressure through lifestyle modifications that's backed by a lot of evidence. The DASH diet stands for Dietary Approaches to Stop Hypertension. So this includes increasing the amount of fruits and vegetables in someone's diet, trying low-fat dairy products, enhancing their intake of potassium, calcium, and magnesium, and fiber, and it's really effective when it's also combined with weight loss. So the hope is that making these changes will also help them lose weight, but it's also going to decrease their sodium intake. We have these DASH seasonings on the left here. They have everything that other seasonings would have, the spices, onion, cumin, whatever is in another seasoning. It's just missing the salt. So these are great recommendations for patients that like flavorful food but still want to make some changes to their diet. And patients can also benefit from being referred to a dietitian so that we can optimize whatever their dietary preferences are, because every patient is unique. Whether they want to try the Mediterranean diet or learn more about the benefits of vegetarian diets, whatever the case may be, it's leaning on the whole healthcare team to optimize the patient's therapy. So speaking of sodium restriction alone is a great way to lower blood pressure in adults with hypertension, especially in high-risk patients, Black patients, older patients, and patients who in general are more sensitive to the effects of sodium on blood pressure. When we're younger and our renal system is working great and all of our blood pressure homeostasis mechanisms are working great, like the renin system and aldosterone, we can kind of get rid of that excess sodium so it won't affect their blood pressure as much. But as we get older and patients of certain races will be more affected by these higher sodium levels. So we want to recommend reducing sodium by about 25%. So what this means is on average recommending about 1,500 milligrams of sodium per day. So in America, the dietary guidelines recommend right now less than 2,300 milligrams. So for patients that are trying to decrease their sodium intake for high blood pressure, we want to recommend about no more than 1,500 milligrams per day. And a lot of excess sodium in the U.S. comes from processed foods, our frozen meals, and also from fast food restaurants and restaurant chains that, have frozen meals that they just heat up and bring out to you, Olive Garden and TGI Fridays and all that. So tips to reduce sodium intake include choosing fresh foods, using food labels to choose lower sodium foods. When you're at the supermarket and you're comparing things, looking at that nutrition label and knowing how to read it and make educated decisions. Using spices and low sodium flavorings like those DASH seasonings on the previous slide, and then also just minimizing our use of table salt. So hopefully we're preparing meals that are tasty and flavorful and savory, and we don't need to have that salt on our table that we then kind of just overindulge in because it's there. So those are some tips to reduce sodium intake. Again, very effective way to decrease blood pressure with just making some lifestyle modifications alone. Another great way to decrease blood pressure is through increasing physical activity. So dynamic aerobic exercise, like cardio, running, walking, using a Stairmaster or elliptical at the gym, and or dynamic resistance training, so strength training, functional strength training, and we want to try to do at least 90 to 150 minutes per week. But even short amounts of exercise have been shown to be beneficial for patients who previously lived sedentary lifestyles. So a lot of patients can get discouraged because, 90 to 150 minutes per week of exercise, that could be 3, 4, 5 days of exercise. And when you're going from, not working out at all, it can seem like a lot, but we have to remind them that even going for a 10, 15 minute brisk walk once a day can already start to make a big difference. And it's all about working your way up to that 90 to 150. Increasing physical activity can also help with weight loss, which we already talked about, can make a huge difference in blood pressure. And also the benefits of physical activity go beyond blood pressure and weight loss. exercise, especially resistance training, has been shown to strengthen bones and muscles. It can reduce the risk of other diseases. So if these patients have comorbidities, it kind of targets a lot of diseases in with one, change. And it can help with relaxation and sleep quality. And restful sleep also contributes to decreasing blood pressure, by decreasing stress levels, and it can help with brain health and memory. So exercise is a great recommendation for any patient that, is physically able to increase their exercise frequency and intensity. So this slide is from a study that shows the different benefits that different types of exercise can have. So I thought it was interesting and wanted to share it with you all. The most important thing, obviously, for blood pressure is that all types of exercise can work with a strong evidence for superior benefit to decrease blood pressure. So that's what those double arrows mean. And you can see that whether the patient is just, doing some walking, doing some machines at the gym, using some resistance bands, doing a little bit of mixed exercise, or even doing HIIT, all of those will work to decrease blood pressure. As far as, if they're also trying to lose some weight, it's shown that aerobic exercise or combining aerobic exercise with resistance training will have benefits. And, as far as if they're trying to increase muscle mass, obviously aerobic exercise isn't going to do much of that. You're going to have to add in some resistance training. But this slide is just kind of there to show that it doesn't matter what type of exercise they do, there will be some benefit in terms of decreasing their blood pressure. Alright, so now moving on to alcohol consumption. So the guidelines have pretty clear recommendations on how much alcohol someone should be consuming that would be considered, I wouldn't say healthy, but healthier than if we were consuming alcohol in excess amounts. So for men, we want to shoot for no more than 2 drink equivalents per day, and for women or lightweight persons, and this is not as in like, oh, I have 1 drink and I'm drunk and I'm a lightweight. This is literally saying like if you are, smaller in weight, then the recommendation is no more than 1 drink equivalent per day. And why do we use the phrasing drink equivalents? It is because, not all alcohol is created equal. So 1 12-ounce bottle or can of beer is equivalent to 5 fluid ounces of wine. So a 5-ounce pour of wine, that's like the usual amount that you would get if you went to a restaurant and you asked for a glass of wine. At home, might be a little more or a little less than that, right? But this is to show that, different, and, when we look at just straight shots and things like that, it's even a smaller amount, right? And it's all comparing that each of these has about the same amount of pure ethanol, or the alcohol, right, content in them. So when we're referring to, 2 drinks per day or 1 drink per day, we are talking about the alcohol content, not so much the fluid ounces of that drink, because they vary from drink to drink as far as how much alcohol is actually in them. Alright, and then lastly, for evidence-based lifestyle modifications that we can make, smoking cessation obviously is an important one. We already did our whole lecture on smoking cessation, so we're not going to go real deep into it here. I will say one thing though, some studies have actually shown that smoking can decrease blood pressure, and sometimes this is because smoking actually decreases body weight too. So when patients try smoking cessation, this can actually lead to an increase in blood pressure because they're gaining some weight back. So this alone, though, is not a reason to continue smoking. This will eventually even out, and in the long term, the benefits of quitting smoking outweigh the potential risks of, gaining some weight and having a slight increase in blood pressure because of that, right? They can always try to put that weight back off through healthy ways like exercising and dietary changes, right? The risks of smoking include cancer, pneumonia, stroke, heart disease. So all those risks, obviously, we want to try to mitigate by encouraging smoking cessation. And also, cigarettes can have effects on some blood pressure medications and make them not work as well. So, multiple reasons why we want to encourage smoking cessation. So this is a summary table of all the lifestyle modifications we just went over. So to summarize, weight loss, really great way to bring down blood pressure, very effective. So the intervention for that, obviously, is to lose weight. And the goal is to try to get at least a kilogram reduction in body weight for, every millimeter of mercury we're trying to reduce in their blood pressure. But of course, we want to make sure that we are not going under any healthy BMIs. So we're still trying to get them to that healthy BMI and not obviously go over that and encourage anybody to be underweight. And we can see here that by doing that, the average blood pressure that we'll see, the average change in blood pressure we'll see in patients with hypertension is about 5 millimeters mercury. And then this normal tension just means that, even in patients without high blood pressure, we can see that making these changes will still also bring their blood pressure down some, which is great for those patients that, have normal blood pressures or have elevated blood pressures but aren't fully diagnosed with hypertension yet, that there's still some benefit of recommending these lifestyle changes for those patients. Then for a healthy diet, obviously the DASH dietary diet is the most recommended change to decrease blood pressure for those patients. Reducing sodium intake, again, the goal is, no more than 1,500 milligrams a day. If we are able to, if patients can tolerate it, we can even recommend 1,000, which would have obviously even greater benefit. But again, in the United States, on average, the recommendation is like 2,300, and even then, a lot of us go way over that to begin with. So for some patients, it might not be achievable to get them down to that 1,000. Enhancing intake of potassium, we only briefly talked about that one, but again, low levels of potassium can contribute to high blood pressure, so we want to make sure that they're getting a good amount in their diet. And then physical activity, we talked, that different ways to exercise all decrease blood pressure pretty effectively, and we're shooting for that 90 to 150 minutes a week, but we can, start slow and work our way up to that. And then lastly, alcohol consumption. For men, no more than 2 drinks a day, and for women, no more than 1 drink a day. And again, this is just a summary of all the lifestyle modifications we just talked about. There's a lot of evidence supporting that all of these can lower blood pressure. Now, I just said that all of those had evidence of lowering blood pressure, but we have some honorable mentions here, things that probably still need some more studies until we can fully support their usage to lower blood pressure. But some, small studies have shown that probiotics can make a difference in lowering blood pressure, stress reduction, increasing protein intake, increasing fiber, flaxseed or fish oil, supplementing with calcium and magnesium, and again, other diets besides the DASH diet that might be beneficial for some patients, and behavioral therapy too, like yoga, meditation, biofeedback, all of that probably aiming to reduce stress levels. So we'll take a break here and do a Quizizz before we move on to part 3 of this lecture, where we really get into pharmacotherapy. So the code for this Quizizz will be on Canvas and also in the description of this YouTube video. If you have any questions on the Quizizz, please reach out to me, and I'll see you guys in a little bit for part 3.